Welcome to Chapter 22. Here we will talk about management of patients with upper respiratory tract disorders. This starts in your text on page 538. When we look at management of those patients with upper respiratory tract infections or upper respiratory infections, also known as your URIs, you want to know what's involved when we talk about those upper respiratory disorders and how they affect the body. You also want to look at who they affect. So, for purposes of this course, we'll look at how they affect the older adult. And you can find that in your text on page 539, chart 22 1. Here we will look at some of the common URIs, and for purposes of this chapter, we'll abbreviate them and say URIs instead of having to say upper respiratory infections or upper respiratory tract disorders. And one of the ones I want you guys to know, and that is very important, is rhinitis or viral rhinitis, which is also known as your common cold. I do want you to know that they are highly contagious. Although they are fairly common, note that they are highly contagious. And if a group or family members continually get sick from that common cold, one of the things that you can tell them, or that is important for educational purposes, is that the virus does shed for 2 days prior to it even showing any symptoms. So that is why if family members continually getting sick, it is because one family member has it for 2 whole days before they start to show symptoms, and then they have already passed it along to the other family member. So it's a vicious cycle when it comes to that. I also want you to look at the clinical manifestations and pay attention to that medical management. Note that antibiotics are usually not given, especially if viral. We do not give antibiotics for viral things, okay? It is going to self-eliminate. We do not have to give antibiotics. Some of the over-the-counter medications can help, especially with the cough and the nasal drainage. So we want to educate our patients about that as well. Another one that I want you guys to pay attention to is tonsillitis, and that is found in your text on page 548. Again, we've skipped over a few, but I do want you to review the information. I am just pointing out some of the important ones that I do want you to pay closer attention to. And again, we're talking about tonsillitis, and that is on page 548. I do want you to look at the clinical manifestations of that so that you can educate your patients what they will feel and how they will feel, and what you as a healthcare provider may see, and how we as nurses manage that. So look at the nursing management side when we provide that post-op care, especially if they have a tonsillectomy. You want to look at providing that post-op care and how you educate patients about self-care. So again, one of the things when we look at tonsillitis, before they go to the tonsillectomy stage and having them taken out, we want to note that they may be put on antibiotics to see, get rid of that infection, make that inflammation go down. It is very painful. One of the most important things you want to teach your patients is to complete their antibiotics. I know when patients have tonsillitis, the inflammation will start to go down after 3 to 4 days. But we need to tell them and stress that they need to complete the antibiotic therapy. Do not stop. We want them to complete that to ensure that the organism has completely been eliminated. That is one of the most important things we can tell our patients when it comes to antibiotics. Also, I want you guys to look at laryngitis, noting that, of course, what it is, inflammation of the larynx, often occurs as a result of voice abuse. And who can we think of when we think of voice abuse? We think of those opera singers. We think of those performers. They can have laryngitis. So you want to look at the medical management of that and how we as nurses will help our patients care for that. So three of those important things you want to look at is that viral rhinitis, what it is, how it's treated, how we manage it, and from a nursing perspective, what education we're giving our patients. Another one is tonsillitis. How are we managing that? How can we prevent it from happening? What are some things that we can do as nurses to help our patients who do come in contact with this? Here you will see an illustration of rhinitis and rhinosinusitis. I know I told you guys to pay close attention to the viral rhinitis, which is that common cold, but when you look at rhinitis itself, you want to know what that actually is, because it's a group of disorders that's characterized and that talks about the irritation of the mucous membranes of the nose. So when looking at that, you also want to look at what you're going to educate your patients on. And most of that is pertaining to self-care. So one of the most important things you want to educate them about when looking at these disorders is medications. Note that if they're taking medications for these disorders or these infections, that they are aware of both the interaction for the medication and any over-the-counter medications that they may take. A lot of people, especially our older elderly population, will take those herbal supplements and over-the-counter medications, and so we want them to be aware of that and any interactions that may occur when taking those prescription meds as well. So they need to read their drug labels very carefully prior to taking any of that over-the-counter medication. Again, if your patients have something such as rhinosinusitis, here you will find an illustration of pharyngitis, and we didn't talk too much about that, but you can review that information and what it is and how it affects the upper respiratory portion. Here you will find a true or false statement in regards to acute pharyngitis. And here is the answer with the rationale. Now, when we look at some of the complications that can occur when we look at an upper respiratory infection, there are numerous things that can occur, but we do not want them to happen. I'll point out some of the more important ones and what we should do to eliminate those or diminish those from happening. So one of the major ones is, of course, airway obstruction. We want to always have a clear, patent airway. So depending on what the upper respiratory infection affects, which part of that upper respiratory tract, we need to make sure that the patient has a patent airway. And just for some examples, you can see or understand that tonsillitis, their tonsils will be swollen, and this can impede their airway. Laryngitis, they'll have inflammation of the larynx. This can sometimes impede their airway. Um, there are numerous things that can obstruct the airway, and so we as healthcare providers want to make sure if it is something inflammation related, we need to decrease that inflammation. If it is something that is going to keep reoccurring, we need to eliminate that from happening. This is why sometimes they take out the tonsils, because they continuously have tonsillitis and it impedes the person's airway. So you want to note that airway obstruction is a major complication. Although they are rare, they can occur. So we don't ever want to say never. If your patient has dyspnea, which is that difficulty breathing, you want to rate that on a scale of 1 to 10. You'll relate that just like you relate pain. So if your patient is telling you they're having trouble breathing, ask them, how bad is it on a scale of 1 to 10, with 10 being I can't hardly breathe at all, to 0 being, oh, I can breathe, but I just have, episodes of difficulty. So you want to get that and document that, because that may be leading towards your airway obstruction. So that is one of the major ones. Another major one, of course, is sepsis or meningitis. Those are very, very potential potent complications that can occur. We do not want them to occur, but we need to be cognizant of any signs and symptoms that may occur. And so we want to provide that nutritional support, of course, emergent care for that, treating that infection, stabilizing those vital signs for those patients, and providing that support, IV fluids, corticosteroids, and of course supporting that patient and that family. Another one that is important to look at is acute otitis media and rhinosinusitis. They may develop with the upper respiratory infection. So you want to make sure you instruct the patient and their families about those signs and symptoms as well, and of course about the importance of follow-up care. Going back a little bit, like I talked about the tonsillitis and antibiotics, this requires follow-up care. And I know a lot of patients, once they start to feel better, they will not go for their follow-up care. So these are important to educate your patient about. When looking at the nursing assessment, of course, you want to get a good health history. Any signs or symptoms such as your headache, a cough, hoarseness, loss of voice, any inflammation, fever, any stiffness in that generalized upper respiratory area, any discomfort, any increased fatigue. Of course, assess if they have any allergies. This is important because we do not want to give any kind of medications or provide any kind of interventions that may, of course, harm the patient further. And then you, of course, want to inspect the nose, neck, throat, palpate any lymph nodes, see if you can palpate any structures in the upper respiratory area. Here's a question in regards to palpating the upper respiratory infection. And here's the answer with the rationale. And here are a couple of nursing diagnoses when we look at the patient with an upper respiratory infection. And as far as planning, when we look at that nursing process, of course, most importantly, maintaining that airway, reducing that risk for any aspiration. So we want to get that swelling under control if that is the issue, get that infection under control, manage that pain. If any of you have ever had an upper respiratory tract infection, know that you have some pain. And I'm going beyond the common cold. I'm talking about bronchitis, laryngitis, tonsillitis, any of those, pharyngitis, all of those are associated with pain as well. So make sure you're medicating your patient appropriately, especially if they're in an inpatient setting. Of course, communicate with your patient. If they have hoarseness or loss of speech, they may have to write things down, but speak with them as often and clearly as possible. Avoid having them strain to talk to you. So if you already know that they're hoarse and you know that they have inflammation, do not force them to talk. Give them a whiteboard or a notepad and have them write down what they need to tell you so that they can save their voice. Also, you want to encourage that hydration. Make sure that your patient is drinking at least 2 to 3 liters a day during the acute phase of the infection, because they can get very dehydrated. Then we'll go into hypovolemia. So we don't want to go from one extreme to the other. We don't want to send the patient toward the shock end spectrum. We want to keep that patient hydrated unless it is contraindicated. So of course, if they have any cardiovascular problems, anything like that, then they may not be able to intake that much fluid. So you want to make sure that your patient is staying hydrated within limits. This is also to thin out any of those secretions and to promote that drainage. And I know I said previously to decrease the fluid or limit the fluid. You don't want to go overboard. And that's what I mean by limiting your fluid intake to promote that drainage. So here it tells you 2 to 3 liters a day. That is what we want the average adult to intake to promote that drainage and thin out those secretions for any of these upper respiratory tract infections. Of course, if you tell people to hydrate, most of the time they will overdo it. So we don't want them going to the far end of the spectrum and drinking 5, 6, 7 liters of fluid, thinking that this will get rid of this drainage. So limit your intake, but we do want to promote that hydration, if that makes any sense. Looking at the nursing interventions, of course, elevate that head of the bed. That helps them breathe. That helps you keep that airway open, okay? An ice collar to reduce any inflammation or bleeding, especially if they've had surgery. You may have to put some ice packs or some heat packs on the neck. That will also reduce congestion. If they're doing home care, I know you've heard of the over-the-counter Vicks salve and things of that nature. Tell them about analgesics for pain, gargle for the sore throats. Most of the home remedies you'll use, salt and warm water. So those are some of the things that they will use. Again, talking about the alternate communication, if they have a strain in their voice or hoarseness, encourage those fluids, eating a soft diet, and of course, rest when you can. Of course, when we evaluate our patients that have had those upper respiratory tract infections, most importantly, what are we assessing? That airway. Maintaining that airway is the most important thing. Of course, the next important is having that pain relief, making sure that our patients are able to function and getting rid of that pain, making sure that they're able to now communicate. Their voice should be coming back. Even if they've had laryngitis, After the course of 3 to 4 days, and they started taking antibiotics and doing this, that, and the other, and resting and gargling, their voice should be coming back. Making sure that they're hydrating. Along with hydrating, they shouldn't be going to the bathroom. So they shouldn't be intaking all these fluids if they're not actually coming out. So again, that goes back to limiting our hydration, but we want to encourage it as well. And then making sure there's no complications involved. Patient education, of course, prevent any upper respiratory tract infections if we can. Frequent hand washing is key. Making sure our patients are following that good hand hygiene. That can diminish the spread of a lot of those infections that we come in contact with. Also, knowing when to call the doctor, especially if you have any type of complication or anything like that. Know when to call. Of course, you would not call for a fever of 99.4 versus you would be calling for a fever of 101.4. So you want to educate your patients about that. The need to complete that antibiotic therapy. I cannot stress enough how important it is to complete your antibiotics and to educate your patients on that. And then, of course, we want to let those who are at risk know about the influenza vaccine, and for our elderly population, our pneumococcal vaccines. Now here we will look at obstruction and trauma of the upper respiratory airway. We will look at a few of these and their importance. The first one being obstruction during sleep. Most of you will think of this as the sleep apnea, and this is what we characterize as that disturbance or reoccurring episodes of an upper respiratory obstruction and reduction in ventilation. So when looking at sleep apnea, I do want you to understand the clinical manifestations, but more importantly, look at the chart when you're assessing your patient for sleep apnea, and that is found in your text on page 554, chart 22-4. You also want to look at how sleep apnea is managed once it is diagnosed. Next, you want to look at epistaxis, which is your typical nosebleed. You do want to look at the risk factors that are involved, which is found in chart 22-5 on page 555. More importantly, you want to look at the medical management of this. So when we look at the medical management of epistaxis, what do you do when the patient is bleeding? What do you think to do first? Most people think, oh, hold your head back and you'll be fine. Well, what if that does not work? And is it really that the patient should sit or hold their head backward? I know everyone thinks that is correct, but the patient should sit upright with the head tilted forward to prevent swallowing and aspiration of the blood, and it is directed to pinch the soft outer portion of the nose. And usually this is done for 5 to 10 minutes versus what everybody thought to do, which was hold your head back and put something up your nose for 10 minutes. That is not correct, because the blood can then drain backwards and then you can then choke on it or aspirate. We don't want the patient swallowing and aspirating on their own blood, so we'll have them sit and lean forward, pinch that portion of the soft spot of the nose for 5 to 10 minutes, and the blood should then clot. So that should stop it. But we'll look further and see what if it doesn't stop. So here it goes over epistaxis and what it actually is. So do understand what it is, and that's your typical nosebleed, okay? And how we manage this. So again, Everyone thought to lean backwards. We're not leaning backwards, we're leaning forward, okay? Tilting that head forward. But if you've done this for 10 minutes and it has not stopped, then what do we do? It can be a serious problem. So, if you've ever seen a person with a nosebleed, it can range from mild to severe. And I have seen it where they are bleeding, like someone cut them open and they are bleeding. Like I've seen it with clots and everything. So, again, look at those risk factors that are in your text on page 555 in chart 22-5. So after we've set forward, we've pinched the nose for 10 minutes, nothing's happening. Our patient's still bleeding. Well, then they'll go to some phenylephrine spray. This spray causes vasoconstriction. So we would think, oh, okay, they're bleeding, hasn't stopped. We sat there for 10 minutes. Now we've sprayed this spray. It's supposed to cause vasoconstriction, which should stop the blood from running. If that does not happen and our patient is still bleeding and we've done the spray and they're still bleeding, we're then going to move to the silver nitrate. So know that we follow this pattern, okay? We tried the holding and sitting forward. We've tried the spray. That hasn't worked. Now we're trying this silver nitrate. If we try silver nitrate, then that doesn't work. We don't really know what's going on and they're bleeding. They're actively bleeding. What are we doing besides watching them? We have to do something. So next it looks like we're going to do a gauze packing or a balloon inflated catheter. Now I have seen it get to this point where they have had to literally pack this person's nose and they have had to suction like the excess clots and the excess blood out of there and then put the gauze or balloon there. So if they do result to that extreme measure, note that it may remain in place for 3 to 4 days if necessary, but it can stay there for up to 6 days before it is removed. The maximum time that this can stay in is 6 days. But at the same token, you want to educate your patients that they are at risk for toxic shock syndrome. And we do not want that to happen. That can also happen with your patients that get tampons stuck as well. So you want to make sure you're educating your patients about self-care and what to do if the bleeding becomes uncontrolled, and also what to do as it becomes controllable. Any risk factors that the patient may be putting themselves in harm's way, one of which is hot foods, spicy foods, smoking. Those are all risk factors. So you want to look at that and make sure you're educating your patient about that and decreasing the use of those things. Here's a quick illustration of the packing to control the bleeding. So when we look at nursing management, of course, we want to maintain that airway. I cannot stress that enough and how important that is. Of course, you want to check your vital signs for those that are hospitalized and inpatient. make sure that they reduce their anxiety or give them some type of medication that can assist in reducing their anxiety, or we can use those non-pharmacological therapies or interventions that can assist in that as well. And then most importantly, patient teaching, educating them on avoiding that trauma, especially to the nose, having adequate humidification to prevent dryness, which may also increase the risk for them to start bleeding again, and of course, what to do if. Now, briefly looking at cancer of the larynx, we won't spend too much time on this, but I did want to point out a few things that I did want you to look at when it comes to cancer of the larynx. This is actually starting in your text on page 557. I do want you to look at chart 22-6, which goes over those risk factors. Risk factors for laryngeal cancer is important. One of the major things you want to ask about is smoking. Smoking is one of the biggest risk factors that will affect cancer of the larynx, pharynx, and the lungs, as well as some other upper respiratory structures. So, one of the most important questions when you're assessing your patients for risk factors of laryngeal cancer is to ask them if they ever smoked. Ask them if they had a history of smoking, if they ever smoked anything in their entire life. I know most people think that asking about a family history is most important, but when we're looking at risk factors, the most important when looking at cancers of the upper respiratory tract in general or overall, we want to ask about smoking first. This is not to discount that family history does or can play a role, but we do want to ask about that smoking. Of course, I want you to look at the signs and symptoms of this disorder and note the difference between the early signs and the later signs and how this patient may present to you in the clinical setting. Here's a true or false question in regards to cancer of the larynx. And here's the answer with the rationale. When trying to make a medical diagnosis of that laryngeal cancer, these are some of the things that you can assist the healthcare provider in doing. Of course, performing that very thorough physical and history. The provider would have to order a laryngoscopy or an FNA biopsy of the larynx to see what is actually going on, and to see if there's cancer cells there. An endoscopy or even a PET scan to see if it has metastasized anywhere else. And then, of course, grading those tumors by the grading system. We won't get too much into that because you'll do more of the grading and the systems when you get in advanced. As for the staging, we won't venture into this realm of the laryngeal cancer just because you will get more of this when you get in advance and you will understand it better as far as stages 1 through 4, not just for laryngeal cancer but for cancers in general. Here's an illustration of changes in airflow with a total laryngectomy. If that does occur and the patient does have to have a laryngectomy, what would be your priority nursing intervention? It should be airway. Airway, airway, airway. We cannot stress that enough, especially if you're dealing with something of the upper respiratory tract. You want to maintain that airway. Taking out the patient's larynx altogether, you want to maintain that airway. So the surgery is extensive, and the patient does have to have a lot of therapy following this. We won't get too much into what they actually have to do after surgery, but the main thing that I did want you to know is that they must, as healthcare providers, must maintain that airway, especially if they have a total laryngectomy. Here we look at the nursing assessment. Of course, you want to do that health history physical. You want to obtain any necessary diagnostic labs or procedures that need to be done. Look at the hearing and vision and how their communication will be impacted after surgery and what they can do to actually communicate until they are healed, or what type of therapy they will need for them to have adequate communication. Here are some nursing diagnoses that one could apply to that of a patient with laryngeal cancer. Now, when looking at collaborative problems and potential complications, of course, what's the major one at the top of the list? Respiratory distress. Another major one that you should look at is aspiration. What can we do as healthcare providers to prevent aspiration? One of the main things that we can do, or that we need to have available, is suction. Suction needs to be at the bedside, as well as oxygen. Those are your two things that should be at the bedside when you have any type of respiratory infection or any type of respiratory surgery that has occurred. Make sure that you're looking for those signs and symptoms of respiratory distress, especially if your patient becomes restless, if they're irritated, agitated, if they start to become confused, if they have tachypnea, if they start that breathing fast. We want to look for those signs and symptoms of hemorrhage, any infection, any kind of wound breakdown. We want to make sure we're looking for that. Maintaining that oxygen saturation above 95. And this is not to say right after surgery, but we want to keep it above 95. Usually, right after surgery, if it's in the lower 90s, we can throw those O2s on them, 2 liters via nasal cannula, and then we can see if that O2 comes up. But we want to make sure we maintain that airway. So again, looking at aspiration, which is important, besides having that suction at the bedside, you want to make sure that if the patient is receiving feedings, especially if they're getting 2 feedings, that they are positioned with the head of the bed at least 30 degrees or higher. We do not want them aspirating. Then, of course, looking at our post-operative nursing care, again, you want to maintain that airway and control those secretions. So make sure you have that suction at the bedside. Reduce any anxiety that your patient may have, especially when it comes to communication and how they're going to communicate. You have to relieve that anxiety, whether it be with medications or a non-pharmacological intervention. Support that alternate communication, and you can refer to chart 22-9 and figure 22-5. You want to promote adequate nutrition and hydration, as well as positive body image and self-esteem, because they have had an alter in their body image. You want to promote positivity. brush you out because you look a mess. Maybe I'll get up and get you a bath in the morning. What's up? What's up, boo man? What's up? Gotta go out? Just came from outside.